behalf of Dr. Abdulsalam Mohsen, our Associate Professor of Ophthalmology in Cairo University. This morning we're going to talk about scleral buckling, vitrectomy, or combined surgery for rheumatogenic retinal detachments with inferior breaks. It's a systematic review and a meta-analysis. In the study group, we had two of our renowned professors. In the study group, we have two of our renowned professors that have participated in this meta-analysis, Dr. Abdulsalam Mohsen and Dr. Ahmed Abdallah Muala. It was presented partly at the British and Irish Retina Society in 6th November 2020, and it's still under review for publishment. Inferior retinal breaks are present in as many as 42% of rheumatogenic retinal detachments. Inferior breaks are defined as being the breaks between 4 o'clock and 8 o'clock inferiorly. They are associated with a higher incidence of retinal redetachment and also a higher incidence of having multiple retinal breaks. And a lot of studies have been conducted on the ability to reattach the retina using different surgical techniques, and there is an ongoing debate whether to use pulse-plan vitrectomy or scleral buckle, or a pulse-plan vitrectomy that's combined with a scleral buckle. So our study aims at comparing the outcomes of different surgical approaches to treat rheumatogenic retinal detachment with inferior retinal breaks through this systematic review and meta-analysis. The studies have been published between 2004 to 2021. 9 of them actually were retrospective studies. 3 of them were randomized controlled trials, and 3 were prospective case series. About 3/4 of the cases in our study, 74%, underwent pulse-plan vitrectomy, and about 1/4 underwent combined surgery, pulse-plan vitrectomy and scleral buckle, while only 26 out of 1,417 eyes underwent scleral buckling, so the number was too little to be included in our meta-analysis. So it's basically a comparison between using pulse-plan vitrectomy alone versus using pulse-plan vitrectomy combined with a scleral buckle. These are the different percentages and contributions to the study. We have macula on detachments, macula off detachments. Most detachments were 2 quadrants. PVRC was not present in many cases. Also, most cases used SF6 as a tamponade. Few cases used silicone, and none of them used air or C3F8. The outcomes were classified anatomically and functional. The anatomical outcome was retinal reattachment, studied as at 3 months and also at 12 months post-operatively. It was also classified into primary and secondary according to the number of surgeries that was used to reattach the retina. Removal of silicone oil was not considered a further procedure or a second procedure because it doesn't aim at retinal reattachment. Functional outcome was the change in the best corrected visual acuity and the proportion of the eyes achieving improvement in visual acuity of more than 10 or more than 15 letters at each time point, also at 3 months and 12 months. As regards the anatomical outcome, at 3 months, we had 342 patients, 276 of which underwent pulse-plan vitrectomy and 66 underwent combined surgery. About 90% of the pulse-plan vitrectomy and about 77% of the pulse-plan vitrectomy combined with buckle had a flat retina at 3 months. Also, macula off detachment were less likely to have a flat retina than the macula on detachment. Regarding the statistics, there was no evidence for a difference in the probability of flat retina according to the surgery type. At 12 months, more eyes were included, 428 patients, about 400 of which were pulse-plan vitrectomy and 29 were combined surgery. About 80% of which of the pulse-plan vitrectomy cases had a flat retina. 96.6% of the combined group had a flat retina. This is when we included the primary anatomical success, which is 1 surgery to achieve the success. If we include 1 or more surgeries at the 12-month interval, the percentage jumped to about 97% in the pulse-plan vitrectomy alone and 96.6% as is for the pulse-plan vitrectomy and scleral buckle. Also, there was no evidence for difference in probability of having a flat retina at 12 months, either after a single surgery or after 1 or more surgeries by the method of the surgical repair used. Functional outcomes, we had also no evidence for difference by surgery type proportion of eyes. More than 10 or more than 15 letters improvement in the best corrected visual acuity. Actually, best corrected visual acuity was readjusted according to the preoperative visual acuity for the comparing macula on and macula off cases. فماكل اوف patients had definitely a larger improvement than the macular on cases. At 12 months, we had 637 patients. It's the largest number till now. 478 post-plan vitrectomy, 159 post-plan vitrectomy combined with buccal. There was an evidence that the combined surgery was the patients were more likely to experience more than 10 letter improvement, but this was no longer the case when the vision was adjusted to the preoperative best-corrected visual acuity. Also, there was a little evidence for a difference in the proportion experiencing a more than 15 letter improvement of the visual acuity. The strength of this study, there was the availability of the individual participant data, the availability of the aggregate data, also the protocol of the review was registered prospectively in the Prospero, an international prospective register of systematic reviews. A few limitations of the study might include the lack of homogeneity in the outcomes and the time points available, because many patients showed up at 3 months and not at 12. Other patients showed up at 12 months, not at 3. The effect of 360 laser or not, combined surgery or not, and the post-operative posturing was not thoroughly understood in this meta-analysis. A little number of patients were treated with scleral buccal alone, as we aforementioned, only 26 out of the 1,400 cases, and it was predominantly from retrospective series. So an adequately powered randomized controlled trial is needed based on this meta-analysis involving more than 300 participants in order to make sure of the results that we had. As a conclusion, this systematic review and meta-analysis found no evidence for a statistically significant difference in the post-operative outcome, whether anatomical or functional, between post-plan vitrectomies combined vitrectomy buccal for the management of rheumatological synaptic attachment to the inferior retinal breaks. And thank you.
Yeah. طيب انا بس احب اسال الجميع، انتوا فاهمين يعني ايه ميتا اناليسيس؟ ده to start with يعني، لان الميتا اناليسيس is one of the highest score، يعني ده on top of the mountain on top of the pyramid يعني. فالميتا اناليسيس بيجيب كل الليترشر وتعمل له كده ريشافلنج وتشوف ايه اللي كان ريلايبل عشان نرجع له. طبعا احنا لازم نعتمد بما اننا scientific people on scientific evidence based medicine. فالميتا اناليسيس ده comes to in a important point. احنا دلوقتي الى حد كبير there is some laziness in the performance of buckles, whether scleral buckles or even combined buckles and vitrectomy. This is something we need to have in mind. الريزلتس بقى بتاعت الستادي دي، although the inside information there is some difference، لكن statistically significance بتقول لنا ان there is no. you have to extrapolate. عشان العدد بتاع سكليرال باكل مع فيتركتومي اقل شويه، فممكن قوي ده يعمل some affection, some turn in the statistics. لكن definitely I think that we should take this in mind. There is no difference statistically، ولكن في الاخر بقى احنا عندنا a very important point we should have in mind. We have now an idea اللي احنا ممكن تأثر العيني ننفذها. There is a lack of clinical trials, randomized clinical trials حقيقية اللي هي تنظر في الموضوع ده. فاحنا ممكن نعمل عندنا في القصر العيني خطة للفترة اللي جاية، بحيث ان احنا we start doing this work، ونبقى نطلع من عندنا من القصر العيني واحنا بنعمل عدد كبير من العيانين اللي احنا ممكن to structure a clinical trial, randomized blind clinical study about this particular topic. لو انتوا سألتوني انا رأيي شخصيا، I prefer scleral buccal vitrectomy. I've been working for a long period of time الحقيقة، لكن I have found that my results in these particular cases with scleral buckling combined with vitrectomy is 100%. Literally 100%. هتقول لي مفيش حاجة اسمها 100%. لا أنا هقول لك بقى 100%. Whereas I used to have some detachments in some of the cases where I used to do only vitrectomy. So I am into the combined surgery، ولكن I urge you all، مش scientific activity reorganize restructure، ويبقى كل الاقسام يبقى عندك داتابيس، كل الداتابيس should be collected، وانت في خلال سنتين ثلاثه هيبقى عندك انت a large cohort of patients which you can publish in this particular topic. طبعا PVR يعني PVR without thinking يعني، لكن if I have a large break inferiorly which is often the case، بس يعني احنا عايزين بس يعني نفرق بين if you have a young patient with an inferior break and it's not, there is no PVR. Scleral buckling alone is an excellent procedure والsuccess rate عالي جدا. ده حاجه، لكن لو large breaks or multiple inferior breaks I elect to go into combined. Of course there absolutely. تماما there is no one single procedure fit for all، and this you have to be flexible and you have to tailor your technique according to each patient.